Hi, I'm Tom Bagwell, and welcome to Hello Health, a partnership with the Ochsner Health System and Humana to bring Ochsner's Hello Health weekly education and information series to you. Our topic this week, migraine headaches, what causes them, how are they different, and new treatment options for dealing with migraines. Our guest is Neurologist Fawad Khan. First, some background. Dr. Khan received his medical degree from the Deccan College of Medical Sciences in Hyderabad, India. He completed his residency in neurology at the University of North Carolina Hospitals in Chapel Hill. He completed his fellowship in neurophysiology and epilepsy at the University of Michigan in Ann Arbor. And he is certified by the American Board of Psychiatry and Neurology. He's also board certified in headache medicine. And it is our pleasure to welcome back to our program Dr. Fawad Khan. Good to have you with us.
Thank you, Tom.
Yeah, so let's talk about migraines. How common are they?
Unfortunately, migraines are more common than we think. They are the sixth leading cause of disability globally. It's actually the third most common disorder for humans in general. In US alone, we have more than 39 million sufferers of migraine headaches. And the number seems to grow because we have patients who transition from episodic migraine, meaning they have less than half the time, migraines in a month of 30 days, less than 15 days. And these patients somehow tend to transition to chronic migraine, where the burden is much higher, so more than 15 days a month. And then the number also grows in a population because it's an inherited disorder, so it transfers from parents down to offsprings.
For the record, you have had migraines, right?
Yes.
So you know what you're treating. And
yes.
Yeah, can empathize with patients.
Yes.
Yeah, and you said they're getting worse, or we're seeing more of them. Do we know why we're seeing more of them?
I think part of the reason is that they are under-recognized and a lot of times misdiagnosed. We have only less than 4% of patients who have migraines actually seek care with the headache specialist. So it's a large population who is not under appropriate care or does not have means or access to the latest therapies or even lifestyle modification or behavioral therapies that are necessary to help control them. And so as a result, it seems like the disease is taking a greater handle over.
The point I know you want to make for this program is that this is not just a regular headache. There's a difference between a regular headache and a migraine.
Absolutely. So on one side, you have a regular headache, which can be mild, moderate, or even severe. And then you go over to the other side where you have a headache which is even more severe, so disabling. And then when a patient has a disabling headache that occurs repetitively, then it becomes further disabling. And that is what's a migraine, because migraine has an impact over the individual as a whole. We know now that more than half of the important and eloquent structures in the brain are involved in a migraine. It takes the brain about 4 days to recover from a migraine. So that's how we distinguish a migraine from what we call as a regular headache.
So what does this mean? Take us into the life of someone who suffers from severe migraines on a chronic basis.
Oh, absolutely. When patients suffer from migraines, they can tell you that their headache is like a story. It has a beginning, it has its more severe part, and then it has an end. And as you walk through that, that's a timeline as we describe for migraines. So there's a premonitory phase or prodrome, and that can happen a few hours or even a few days before headache. Sometimes patients construe that as a trigger. Sometimes the prodrome itself is a change that they appreciate that occurs before the migraine starts. And then this can lead into an aura in some patients, and auras are characterized by neurological changes that patients perceive. For instance, a change in your vision or a change in your speech or your ability to sense your arms or legs. And these are brief. The auras are traditionally brief, less than an hour. And then this can be followed by the migraine itself, the migraine attack, which we call the symptomatic phase, where the headache is a large component of it. But in addition to headache, there's nausea, there's vomiting, there's other debilitating symptoms, fatigue, whole body pain that accompany that. And then there's a postdrome. And that's sort of the aftermath of the migraine, where you can have a constellation of symptoms that occur for hours to even days afterwards. So this is the entire spectrum of the migraine. And that's what distinguishes this from a regular headache, and also why it's so debilitating. And imagine someone experiencing this on a repetitive basis. You're looking at most days out of the month where you're symptomatic from any of these constellation of associated symptoms.
What does the research tell us about the impact of migraines on the brain? Is there real change taking place in the brain?
Yes, so there's growing evidence that different parts of the brain are now involved, both during an attack, so during a migraine itself, but also in between migraines. We've recognized certain areas of the brain. There was a study that recently published, which was an international study, so they had patients from all over the world. And we had more than 131 patients, and we found that when you look at MRI imaging of the brain and you compare that to someone who does not experience migraine, that certain areas of the brain show changes or atrophy. And in atrophy, for instance, an easy way to understand that is those parts of the brain are shrinking. And we think there is some at the cellular level changes and even possibly some destruction of neurons that are occurring. This is in addition to the spots that people describe in the brain, the white matter spots. And so over time, the burden of the spots and the changes in the brain occur and are directly related to the severity of the migraine, the overall burden of the migraine, the duration of the migraine seems to be a big factor in how long an individual migraine can persist in an individual, regardless of the abortive treatment.
You mentioned triggers very briefly, but let's delve a little deeper. What are some of the triggers for migraines?
Yeah, I've seen all sorts of triggers in patients. Each patient is very specific and unique. Sometimes triggers are very easily appreciated, and sometimes they're not. They're very nebulous. And patients can say, I've tried changing everything, and I still can't identify a trigger. Triggers can be as simple as changes in weather, so they have no control or internal, like hormones, dietary, foods, sometimes flickering lights, bright lights can bring on, sometimes lack of sleep, or recovering from an illness or during an illness. There are numerous triggers out there. And what's frustrating about that for patients is that not only are the migraine attacks debilitating, but it's a life that you have to live to avoid these triggers. And right now, sitting in this room, there's numerous triggers that we're being exposed to. And unfortunately, someone who has migraine will tell you that they just cannot tolerate this kind of environment. And so that seems to be what has the biggest impact on their quality of life.
So I'm thinking lights, as I look through the list, lights, stress, although I'm not nervous, I hope you're not. The good news is, however, you notice that the number one trigger is stress. And at the end of our program, Dr. Khan is going to share with you some ways to relieve stress and hopefully assist with migraine. That'll be at the end of the program. So what were some of the medications available and some of the ones we're still using?
Yes. So when we have a strategy to treat migraines, we rely on abortive and preventive therapies. And the biggest focus now is preventive therapies because we obviously want, prevention is better than control or treatment. And when we look at prevention, we have to have a strategic goal. The number one goal is no headaches. Right? That's what everyone wants. But in addition to that, you want to have less frequent, shorter headaches that respond to abortive therapies, less need to use dangerous medications or more sedating medications, if you will. And so that's the ultimate goal of prevention. Despite having such a strong emphasis on prevention, we only have a very small number of medications that are available at our disposal. Right now, through the FDA, we only have 4 medications that are approved in the United States for prevention: valproic acid, topiramate, propranolol, and timolol. Now, a lot of practitioners will provide other medications and use other medications in order to prevent migraines, but all those appear to be off-label and considered investigational at the most in terms of its role in the treatment of migraines per se.
All right. There is some more good news we want to share with you. There are some new therapies available, and the doctors brought along a patient story to share with us. You'll see that right now.
My migraine started in my early 20s. I am 65. I actually taught school for 30 years. There was a whole year of school that I took off because they were just out of control. There were days when the pain was so bad that I would just get through the next minute of the day. Tried all kind of medicines. Try this, wouldn't work. Try this, wouldn't work. And then after years of that, not knowing what to do, I finally saw a neurologist. And I hit upon Dr. Khan at Ochsner. He was the head of the neurology headache clinic. He was very up to date on everything. It was just like a breath of fresh air. I always thought it was genetic. And this particular medication, it's basically a once a month injection. I started taking it, I think in June, thinking it's going to work. It didn't. July, didn't work. August, didn't work. So we talked about it in September, and he decided to try 2 injections a month, which I didn't know was available. That did it. It was what I needed. I went from a good month was 15 headaches. A bad month was in the mid-20s. It was such a drastic change. It dropped to under 10, and the ones that I'm having are not nearly as severe. People who are having trouble with headaches should not dismiss it as just another headache, especially if they're frequent, and shouldn't just take an appointment with any neurologist. They need to do research and find someone who is specializing in headaches in order to get the best relief.
And we thank Ms. Rhonda Tortorich for sharing her story, all the patients who come forward to tell their stories, and the Ochsner team, production team, for putting these together. So what exactly happened with Ms. Tortorich, and how does it work?
Yeah, she brings in a really important point where she's tried numerous therapies. And unfortunately, a lot of patients with migraine are sort of in the same boat, because a lot of the therapies that are currently being used now, the oral therapies, the ones that you take every day, come with a lot of side effects. There's numerous studies and there's data out there which tells us that patients actually don't stick to these therapies. About 85 to 90% of patients actually within a year will change their preventive therapy. So regardless of how effective it is, they end up either going to a different therapy, switching, or stopping altogether. And the number one reason for this is tolerance. The inability to tolerate these medications because of the side effect profile. So that led to the rise of a new line of therapy that would not only be effective or more effective than what we currently have, but would provide better tolerability.
This is CGRP, right? So what is CGRP, and what do we need to know about it?
All right. So CGRP is a neuropeptide. It stands for Calcitonin gene-related peptide. It's commonly available, throughout the body. It has certain unique functions to it. It has 2 isomers, an alpha and a beta, and both are very similar in terms of its function. It is populated densely in the brain and more significantly in the trigeminal nucleus. It has 4 key roles. It causes vasodilatation, it causes inflammation, it causes propagation of pain in its pathways, and it also is involved in healing of motor neurons. In fact, when we first discovered this back in early 1980s, we recognized that this is the same neuropeptide that's involved when you apply pain creams, the topical over-the-counter pain creams, capsaicin. That slight burning that you experience in the first few minutes to hours after application of the cream is the sudden relief of CGRP in the skin.
How is this related to migraines?
All right. So the relationship between CGRP and migraines is complex, and numerous studies have looked into this. And the very first study that sort of brought this out was that they understood that CGRP controls the vasculature in the brain, and it's involved in blood flow. And we know that migraine, to some degree, is a disorder of the neurovascular system. And when we tried to explore that further in experimental studies, there was one study in particular done by Dr. Goldsby, wherein they took patients who had migraines, and immediately during and after the migraine, they did a blood sample of the jugular vein and found that CGRP levels went almost double. And that was sort of the first indication that CGRP tends to have a direct relationship. And then studies came after that, which looked at provoking a migraine with certain medications and found the same thing, CGRP would rise. And then the flip side is that we would treat the migraine and we see the CGRP level come down. So now there seems to be like sort of one-on-one direct correlation with CGRP. And then there's a study, as you can see, which shows the different locations of CGRP within the peripheral nervous system, which is responsible for the different mechanisms that are involved in migraine. We call this peripheral sensitization and neurogenic inflammation. And then you can see the levels of CGRP and how high they are in relationship to when a patient is not experiencing migraine. When you try to simulate the data, our understanding of CGRP is growing, but it seems that there are three basic mechanisms which explain how this works, and they're related to the site. So in the trigeminal nucleus, which is inside your neck, where we think that's the origin of migraine, there are cells surrounding the neurons called the glial cells, and these release CGRP, and then that leads to a cascade of inflammation that goes on. In the periphery, so where these nerves supply the meninges and the dura, which is another site which is responsible for the propagation of migraine, there's inflammation there, and CGRP is released. And then the other mechanism that we know, interestingly, is that when you inject CGRP, for instance, into the skin, you see a vasodilatation. Although the CGRP, the life of the actual molecule is about 7 minutes, the half-life, but the effect can last almost 12 hours. So now we understand that this molecule is somehow released and causes a snowball effect. And that snowball effect is what leads to the propagation of migraine.
Can we block it? Can we block the molecule? And if so, how would that help with migraines? Absolutely.
So in theory, we can, and we did. Early 2000, we began the development of these drugs, which were called gepants. And the idea of these drugs was to block the receptor. So CGRP falls on a certain receptor, and that leads to the cascade of inflammation. If we block that, we can block migraines. And they were found to be very effective. The studies demonstrated that this was a very unique and effective abortive therapy, which was superior to triptans, because triptans also block CGRP, but they come with sort of a baggage of side effects that the gepants didn't. Unfortunately, about a decade, or less than a decade, we realized that the gepants were associated with hepatotoxicity because the liver was a main channel for them to be cleared. And that resulted in sort of arrest of the development of these gepants. A few years after we started understanding the mechanism behind how the gepants were working, we also started exploring other means of blocking CGRP that would work in a similar manner as the gepants, but would not lead to the toxicity that we see with the gepants.
So what has developed? What's new here? What's exciting?
Okay, so I will introduce a concept called monoclonal antibodies. And that's a unique technology that was applied to the same science wherein we know that CGRP has a direct relationship to migraine, and if we somehow block it or block its receptor, that we can abort or even prevent migraine. And monoclonal antibodies are unique because they can do the job, but without the side effects. So in order to talk about, or to understand monoclonal antibodies better, let's talk about the immune system. So in human serum, we have 5 classes of antibodies, and of them, an IgG is the most common, and it's also one of the largest antibodies. And it's not necessarily associated directly with inflammation or a reaction the body has, but you need that as part of your immune surveillance. Monoclonal antibodies are synthesized antibodies. They're artificially produced to mimic the IgG. And what they can do is that it's like a lock and key mechanism. They can find a target, hold on to the target, and block the target from doing its job. And when we know that CGRP is a target, and we're focusing on what's called targeted therapy, because previously we never had medications that worked specifically for migraine or the disease. We had medications that were discovered for other diseases, but were used because of the effect that we saw. Whereas monoclonal antibodies would specifically target CGRP or its receptor, and that was designed exclusively to help with migraine treatment and prevention.
Is monoclonal antibody a new technology?
Actually, no. Monoclonal antibody, Tom, was first synthesized in 1975. And they are now more than 60 monoclonal antibodies that are FDA approved for various clinical applications. We use them in diagnostics for viral and parasitic infections. We use them in therapeutics, in cancer treatment. We use them for numerous other disease states, Crohn's disease, multiple sclerosis, and we even use them in pregnancy tests. And so we're starting to learn more about this, and now more than 500 are in clinical development just because of the safety profile for various diseases. The story about monoclonal antibodies is really interesting. I'll take you back into sort of before the 19th century when we knew about a B-cell cancer, blood cancer called lymphoma, wherein your body produces lymphocytes which produce antibodies. But this cancer causes an abnormal reproduction of these lymphocytes, and it leads to the excessive production of these antibodies. Three scientists understood that and wanted to use that as an application to see if they can actually synthetically manufacture these antibodies. And they used a process called somatic cell hybridization, where essentially what they did is they took these tumor cells and they took normal lymphocytes producing antibodies to a particular target and then merged them together. So now you have this unique cell line which has dual properties. It can reproduce rapidly and produce identical cells, and it can produce antibodies to that antigen it was programmed to do to begin with. And they did this in a mouse model, and it was successful. And so these three physicians are now the pioneers in what we call as monoclonal antibody therapy, and for which they received the Nobel Prize in medicine physiology.
I'm assuming they're safe or they wouldn't be doing it, but are there
Yes.
any risks involved?
Well, when you look at just the evidence, several thousands of patients have been studied in clinical trials, and directly related to monoclonal antibodies, we haven't seen any side effects. When you look at the migraine population and the therapies that I'll talk to you about that were investigated, we found no side effects related directly to the monoclonal antibodies. Now, we do have to understand that these are different from our regular oral pills that we take every day as a preventive strategy. They're much larger molecules, so they cannot be given orally. They have to be given either intravenously or subcutaneously or intramuscularly. So that's one thing which makes them different. The other thing is that these are antibodies, and they're foreign to us, right? That's not what we're producing. So when you introduce something foreign to the body can say, well, this is foreign, let me react to it. It's called immunogenicity. So there is a chance to develop immunogenicity. We've been lucky that the drugs that were developed specifically for migraine have not shown any significant amount of immunogenicity that would alter either its efficacy or cause a safety concern. But for other disease states, for instance, rheumatoid arthritis, the monoclonal antibody that is used, there's a high chance of developing that, which leads to the decline in efficacy of that particular drug. So that's certainly a possibility.
How is this being used now to treat migraines?
So since 2004, we investigated 4 different monoclonal antibodies for migraine prevention. And these monoclonal antibodies have gone through phase 1, phase 2, and phase 3 studies. The data for this is compelling, and it has shown that all 4 were effective in reducing the frequency and burden of migraine. Also, there were other secondary endpoints related to quality of life that also showed improvement with regards to these monoclonal antibodies. And 4 separate companies decided to develop these products over time, and now we have 3 of them which are FDA approved. They were approved in the second half of 2018.
I think you brought along a chart too. We can show that to people as
yes.
we're talking about them. So
Right.
some of these are FDA approved.
Correct. We have 3 which are currently FDA approved, and they differ slightly from one another. Aimovig, Ajovy, and Emgality. 3 different manufacturers for these. Aimovig, which is erinumab, it blocks CGRP receptor. So the receptor is also implicated in the cascade of inflammation that occurs. And these are humanized monoclonal synthesized antibodies that block just receptors specifically. Ajovy is the other monoclonal antibody which was manufactured. And this is different in the fact that it does not block the receptor. It blocks the CGRP itself. So all the CGRP that is floating around in the bloodstream is what's the target for this particular monoclonal antibody.
Any other strategies quickly that can help patients? And then I want to talk about stress management and diet management.
Sure. I'll finish with the third one, which is Emgality. Emgality works very similar, that it blocks CGRP, the molecule itself, and can be given once a month, and has a loading dose as the very first mechanism. All three are available, and there's no comparison because we don't have that kind of data as to which is better, which is worse, but they all seem to be well tolerated. Coming back to your point as to other strategies. So we talked about preventive strategies using pharmacological agents. The picture when we look at prevention does not stop there. We need to see things in a much more broad, in a holistic standpoint. And when we look at from a holistic benefit to the patient, I look at stress reduction or stress management and dietary management. And stress management is very important. And this sort of contradicts the stigma. And I have some patients coming to me and saying, well, doc, I have stress. Stress is bad. I get it. And everyone has stress. So how different is that? What they don't understand, and what I try to express to them, is that the patients with migraine, their nervous system is different from patients who don't have migraine. Their ability to tolerate stress and how they respond to stress is different from someone who does not have a migraine.
What about diet management?
Yes, diet is also critical because you are what you eat. And it's really important to have a balanced, a healthy, and a consistent diet. And a lot of times with temptations with fast food or just our lifestyle, we tend to sort of fall off the wagon on that. So it's really important to keep that in mind. Diet can be a trigger in some patients, so make sure you're eliminating the foods that or drinks that tend to provoke migraine is really important. But also just healthy fruits and vegetables, omega-3, antioxidants, things which break down free radicals, because that's just part of our everyday life. The exposure to free radicals really helps. And whether you want to use a diary, whether you want to have a health coach or a dietitian work with you, diet is a very important and key component when you're trying to control the disease per se, because at the end of the day, you want to win over the disease.
Thank you for the optimism you've provided for people in migraines. I can only imagine, but hopefully we provided some optimism.
Yeah.
Thank you very much,
Thank
Doctor.
you, Tom.
I want to thank Dr. Khan for the education and information he has provided and for his work in the Ochsner Health System. To make an appointment with any Ochsner physician, including this week's guest, or to register for any of Ochsner's Hello Health seminars, you can call Ochsner at the number you see on your screen or send us an email. There's our address, hellohealth@ochsner.org. As a reminder, you can rewatch this week's presentation or many of our other Hello Health programs on Ochsner's website. Thanks again to this week's guest. Thanks to Humana and Ochsner for making our program possible. And our final thanks is to you. Thanks. We'll see you next time right here on Hello Health.